without further ado, Michael West.
Hello. My name is Michael, and it's a huge privilege to be here this morning and to have the time to share some thoughts and ideas with you. Nominated for HSJ Provider Trust of the Year. I think I should be listening to you rather than vice versa. It's a huge accolade, so it feels even more of a privilege to be invited. So a big thank you to Angela and Chris, and also to Julie as well, who I think played a part in giving me an opportunity to be here. So I want to ask two questions. How do we respond to the huge challenges that face us in trying to meet the health and care needs of people in our society, in our country, in our communities? The challenges at the moment are just enormous. How do we respond to those? And the second question is, what can I individually, each of us individually do that will really make a difference? So what really strikes me forcibly is the recognition that in trying to respond to the challenges that we face in caring for the well-being of our communities, for trying to help people to be the best that they can be in their lives, we're damaging the health and well-being of the people that we ask to deliver that care. So we know that more than 50% of NHS staff say they're not able to manage all of the competing demands on their time at work. That every year something like 40% of staff say that they've been unwell as a result of stress at work in the previous year. And in the most careful, rigorous study that's been conducted, that revealed that 50% more staff in the NHS reported debilitating levels of work stress compared with the general working population as a whole. More than 1 in 4 had what would be classified as minor levels of psychiatric morbidity because of the level of stress that they were under at work. So this is a fundamental paradox, that we have a sector that's focused on promoting the health and well-being of people in the community, but in the process of doing that, we're damaging the health and well-being of the people we ask to deliver that care. And it tells us that something's very wrong. We also know that it has an impact on the quality of care that we're able to deliver. It affects error rates among staff. It affects people's ability to be compassionate in their interactions with patients and service users. In the acute sector, it's associated with higher levels of patient mortality. And the important thing to recognize is it doesn't need to be this way, because we've got examples of some trusts where stress levels have been substantially reduced and maintained at quite a low level. But across the service as a whole, there is this paradox that tells us that something is very wrong, that we're damaging the health and well-being of you, the people we ask to deliver care. And it's not just, we're not just talking about people being a bit worried. We know that chronic stress is associated with coronary heart disease, with early mortality, with family breakup. So it is a hugely serious issue. So what are we to do? What are we to do? There are lots of national initiatives. Chris was talking about system transformation partnerships. There are accountable care organizations. There are vanguard sites. There's the 5-year forward view. There's efficiency reviews, all very important initiatives. But I don't think that they really get at the core cultural problems that are associated with staff stress and staff experience in our organizations. And those are often to do with either lack of leadership within our organizations or simply poor leadership. So I think to respond to these challenges, we have to go back to the core of what the National Health Service is all about. When the NHS was set up, as you know, in 1948, it was set up with a commitment. It was by a post-war generation, traumatized by the end of a recent war, and with a commitment, as you know, to offering high-quality care free to everybody, regardless of wealth or prestige or status, background. And I think it was expressing a core national value of compassion, that we wanted to be a compassionate society, caring for everybody who needed care. I was reflecting, you know, my mother, who was born in 1926, her father died when she was 9, and there was a family of 5 with no income. And she was telling me the idea of going to see the GP in their family was just not considered, because they couldn't. I don't know if she remembers rightly. She said it was 2 and 6pence to go and visit the GP. I don't know if that's right, but the point is, we transformed our society in 1948, and we've remained fiercely protective of the NHS ever since. You know, I always kind of think of the Olympics opening and the celebration of the NHS, and I think about our national elections, and always the NHS is 1 or 2 in the issues that are discussed. We're fiercely protected because, I think, as a society, we want to be compassionate communities. And all of you made a decision at some point to dedicate a huge part of your unique, precious, mysterious lives to caring for your fellow human beings, that your fellow members of your communities. So you too embody that core work value of compassion. So what is compassion? I mean, it's a kind of warm, fuzzy word. It's hard to disagree with. For me, it's the healthcare assistant I saw who stayed for an hour after her shift had ended, holding the hand of an elderly lady who was in distress and talking to her lovingly and caringly until she was calm again. Or the GP who told me recently she danced in her surgery that day with a lonely elderly man when she discovered they had a shared interest in dancing. Beautiful. And I'm sure you both model and see examples of compassion every day in your work. But just to probe a little deeper, I think to understand compassion, what it means in practical terms, I think it has 4 elements. So, what's your name?
Megan.
Megan. This is going to be perfectly safe, I promise you. So if you're in distress, Megan, then for me to be compassionate, first of all, I have to be present with you. I have to pay attention to you. I have to be here and now with you. To use Nancy Klein's lovely phrase, I have to listen to you with fascination. And second, I have to arrive at an understanding of Megan's distress. Ideally, that's through a dialogue with her, through talking and listening. And third is I have to have a feeling response, an empathic response. I have to feel your distress at some level without being overwhelmed by it, because that gives me the motivation for the 4th step, which is to serve you or help you with your distress. Make sense? Those 4 elements: attending, understanding, empathizing, and helping. You feel better already?
Oh, yes.
So, and we know that when NHS staff give compassionate care to service users, to patients, that patients are much more satisfied with the care they receive. And that in turn has an effect on staff well-being and staff commitment, motivation. So we get virtuous cycles of compassion. And the challenge for us is, picking up on the vision of the trust, being a leading provider of outstanding and compassionate care. The challenge for us is, how do we nurture cultures of compassion? Culture, the way we do things around here, the norms, that this is the way we have our interactions occur. They're compassionate. We attend to those that we're providing services for. We listen to them with fascination. We understand, we empathize, we serve them, we help them. How do we create cultures of compassion? Well, we know that what's critical to the cultures of organizations is the leadership. Of course, every interaction by every one of us, every day, shapes the culture of our organizations. But leaders play a particularly powerful role. What you as leaders pay attention to, what you monitor, what you talk about, what you reward, what you model, tells everybody in the organization what it is that you value, what's important to you. So I think if we're to create cultures of compassion, that our leaders have to model compassion in how they lead. So what that means is leaders who pay attention to those they lead, leaders who listen with fascination to their staff, leaders who seek to understand the challenges that their staff face, ideally, as I said, through a dialogue, because then it's a shared rather than an imposed understanding, and it's likely to be more helpful and more accurate. And third is leaders who feel for their staff, who empathize with them. And then leaders who serve their staff, who help them. And after all, that's what leadership is about, is helping those we lead to do the jobs that they want to do, to provide high quality care, to provide continually improving care, and to provide compassionate care for people in our communities. So those 4 leadership behaviors, I think, are not difficult to remember. Listening with fascination to those we lead, understanding, empathizing, and then serving those we lead to help them do the jobs they want to do. And if we all practice those behaviors in our leadership, not just those behaviors in relation to service users and patients, not just in terms of interactions but between staff, but from leadership to those within our teams, then we really begin to transform the cultures of our organizations. Does that make sense? That's it, I've finished. That's all I wanted to say. The main message. Well, 1 or 2 other things as well to add, but that, I think, is the most important message. If we can model those behaviors, we begin to transform our cultures. Last year, any questions, by the way? At any point, if you want to ask questions or make comments, do intervene. Okay, so last year in December, the national bodies which oversee the NHS, 12 of them listed here. Just think about that for a minute. The absurdity of having 12 national bodies all interfering and sticking their fingers in and having competing objectives adds to the difficulties that provider trusts experience. But the 12 national bodies sponsored a new national framework focused on leadership development and improvement skills within the NHS. And the first principle was the development of collective, compassionate, and inclusive leadership at all levels within the NHS. And that feels really powerful and important. Second was a focus on knowledge of improvement methods, so how to help staff develop improvement skills. And third was leadership equipped to deliver high-quality healthcare. The point of that is a recognition that in many areas of the NHS, there are leadership vacancies, there are interim posts, there are people who've had to have their arms twisted to take on the role of, for example, clinical director. And a recognition that we often don't have the leadership that we need in place with the skills and the capabilities and the compassionate values necessary to create the kind of cultures that we want to create. And also making sure that the national bodies start to take a much more enabling, supportive approach to working with provider trusts. Instead of being punitive and condemnatory, beginning to be focused on improvement and appreciation and being supportive, but also making sure that those 12 bodies start to align what it is they're doing so they're sending consistent messages. And it's also about making sure that support systems are provided for trusts at local level, but also at regional level, and interventions at national level too. So, you know, it doesn't mean that by publishing a national strategy that these national bodies are suddenly going to start to change their behavior, because their cultures need to change to become more compassionate too. But it is an important step forward. Any questions? How are you doing? You with me? So in relation to leadership, I've said I think it's really fundamental that we adopt a compassionate leadership approach. A couple of years ago, we reviewed all of the research on what are the characteristics of healthcare organizations internationally that deliver really high quality care, that perform really excellently. And what emerged from that was the worst leadership approach in healthcare organizations is command and control, directive, hierarchical command and control. The best type of approach is collective leadership, which involves moving away from hierarchy and command and control towards a situation where everybody feels that they have leadership responsibility within an organization, that it's their responsibility and right to speak up when they feel they can make a positive difference in terms of what we're trying to achieve in delivering care. It's an approach to leadership in teams where there's shared leadership. So although Megan may be here, I won't keep doing this to you, honestly. Although Megan may be the hierarchical leader, what's your name? Joe, you know, when Joe has the expertise on a particular task, then the leadership shifts naturally and seamlessly to you. So shared leadership in teams. And third is where there is interdependent leadership. Leaders, such as you, working interdependently across boundaries, prioritizing patient care overall, not just our own individual areas of responsibility. Make sense? But it's also really important that it's consistent. Collective leadership is about consistency. So it's not about everyone having the same personality, but a consistency in our approach to leadership. Which means leaders being authentic, genuine in their interactions. Leaders behaving openly and honestly, transparently. Leaders who are curious, who are always seeking to learn how to lead more effectively. Leadership is never a finished product of asking those we lead, how can I lead you more effectively? What should I do more of? What should I do less of? What really has made a difference? So leaders who are curious about how to learn more effectively. Leaders who are appreciative. You know, one of the biggest complaints from NHS staff is, that I hear, is we never see our leaders unless something goes wrong. And then another complaint is, in some other trusts, it's, well, the board members come and listen to us, and they're really good at listening, and nothing ever changes. Compassionate leadership is about listening and helping. It's making a difference. And the other complaint is, no one ever says thank you. We're not appreciated. We're not recognized. I noted, by the way, this morning, the first thing Angela did was to thank you all. Actually, I think you thanked them about 5 times during the course of your presentation. And as leaders, we all think we're really good at recognizing people's contributions. But actually, given the complaints we hear from the NHS staff, we should increase them tenfold, of saying thank you, of appreciating. As long as it's done authentically and genuinely, it has such a big impact, and the ripples spread out across the organization. And the final, of course, is compassionate leadership. So authentic, open, curious, appreciative, compassionate leadership. It's no good if in one department we have Janine, Joanne, Joe, this Joe, who is this warm, compassionate, positive, supportive leader. It's true, isn't it?
I hope so.
And then in the next department, we've got the other Joe, who's this demonic, dictatorial, punitive. Quite true. We have to have a consistency of leadership style across our organization to build the kind of strong cultures which will deliver for patients. Because how we're treated by those who lead us has a direct impact on how we behave towards patients and service users. Make sense? So just take 2 or 3 minutes around your table for a moment and just share with each other. Well, let's begin by taking 20 seconds, 30 seconds in silence to reflect on what I've said so far about stress, compassionate leadership, collective leadership, and leadership behaviors. What does it mean for me? And I'll let you know when 30 seconds is up, and then share your views very quickly around your table. Okay, is that clear? So just reflect silently for a moment. What does it mean for me? Thank you. And now share your thoughts around the table. Okay, it would be great to hear 3 or 4 thoughts from around the tables of what you discussed, ideas that you discussed. You didn't discuss anything? There's somebody at the back here. Thank you.
Hello, my name's Adrian. We were speaking about, actually, that's the first time we've heard compassionate leadership as a term in the NHS. So we were quite interested to reflect on why is that the case. And we'd be interested to hear your thoughts and views on that.
I was asking the questions here.
Bounce it back.
Well, I think part of the problem is that we have not been good enough at developing leadership in the NHS generally. So I contrast it with, for example, the military. It may seem like an odd comparison, but I see the military as generally being really good at developing team working. Although it's hierarchical, it's very good in terms of team working and developing leadership. Imagine if the Army or the Navy or the Air Force had a situation where they didn't have leaders coming through, a pipeline of people being trained, where you had interim posts, vacancies, where you were twisting people's arms to take on medical leadership roles or military leadership roles. I mean, it's inconceivable in a life and death situation. But I think in the NHS generally, we have not been very good at making sure we're creating the leadership that an organization like this needs. So the approach to leadership, I think, has often been quite a defensive approach. People who think that command and control and direction and punitive approaches work. And I think that that reaction comes from a lack of confidence. A lack of confidence that giving people who are highly skilled and highly motivated the freedom to do their jobs in the way they want to do, and building team working and creating climates of trust and optimism and compassion is the way that we run these organizations successfully. So I think it's a historical problem also based in the kind of long, the legacy of the NHS emerging, as it were, from hierarchical organizations. And also the professional differences. Does that make sense? Thanks, Adrian. That really pushed me. Thank you. Chris.
We were reflecting on what you said about stress earlier, and that we felt that actually if you're very stressed, it's quite hard to be compassionate.
Yeah.
And we thought it was a good idea for people to move into that space to be able to be honest with colleagues and their teams. Because if you say, look, I want to do compassionate leadership, but actually I'm really stressed at the moment, then people can support you and you can share that rather than it just sort of seeping out. So we thought that being able to be honest about the pressures would help with the compassionate leadership.
So one of the, clearly one of the characteristics of work in our organizations is that we deal with really distressing situations, among service users or amongst patients. There are times, when what happens is really awful and really harrowing. And we know that it's not reasonable to expect staff just to kind of jump up and carry on as though nothing had happened. We have to acknowledge and honor those difficult feelings staff experience. So one of the initiatives that's in place around NHS organizations is Schwartz Rounds. Are you all familiar with what Schwartz Rounds are? No? So Schwartz Rounds it was something that was brought in from the US. I'm not advocating that you should do this, but it's an example of how we deal with negative experiences. So it involves bringing staff together on a regular basis, always with a free lunch, to talk about generally difficult negative experiences, emotional experiences that have happened, sometimes positive experiences as well. And the initial data that we have is that the more staff attend those, the more regularly they attend those Schwartz Rounds, the lower their stress levels. So that's a kind of way of institutionally acknowledging the difficulties of the work that we do. But it's also, I think you're absolutely right, the more as leaders we can acknowledge where we are and talk about our feelings when we're really under high pressure, the more we're creating a climate where it's acceptable to acknowledge levels of stress and difficulties. Because this business of compassion, it's not just about compassion between staff and patients, it's about compassion between leaders and their staff in two ways, and between staff members and each other. The reason I'm emphasizing leadership particularly is that what we see when we survey people in NHS organisations is they say levels of compassion from staff to patients are very high. Levels of compassion between colleagues are not too bad either, but levels of compassion from leaders towards their staff are generally not as high as would be desirable. Other comments, please.
Hi, I'm Phil. I was reflecting that I was fortunate to be able to attend mindfulness-based compassion exercise yesterday morning at Campbell House, which is facilitated every Monday and Tuesday mornings. Some of my colleagues weren't aware of that, so it's about, how do we communicate that these things are available. Also fortunate that I'll be studying compassionate focus therapy in the future to be able to share with the clients that I work with and colleagues also. And I was saying it's great that we need to be compassionate towards our patients and each other, but the first thing is to be compassionate towards ourselves, which we need to prioritise.
Yeah. So, and I think that's really helpful. What's your name, sorry?
Phil.
Phil. I think it's really helpful, Phil, because the value of mindfulness in mindfulness practices, it seems to me, in terms of leadership, two things. One is it's a way of learning to be present. And if the first behavior of compassionate leadership is being present with those we lead, attending to them, then by practicing mindfulness, we become more skilled at that. And the second is, to go back to Chris's point, is that the more mindful we are, the more we can be aware, oh, how am I feeling at the minute? I'm feeling really under pressure. I'm in danger of driving myself just more and more and more. So that the mindfulness practices can help us be aware of where we are as leaders. And therefore, if we are under enormous stress, of our reduced ability to be compassionate towards those we lead. And then to practice, as you say, self-compassion. What does that mean? It means paying attention to myself, each of us, paying attention to ourselves. Understanding the challenges we face in life and in work. Empathizing with ourselves. And then taking intelligent action to help ourselves in order that we can live our lives and our work lives more effectively. Really helpful, Phil. Thank you. Please, another comment over here.
Hello, hi. I work in a liaison psychiatry service at the Acute General Hospital. And I come across quite a few of my colleagues from the surgical teams or orthopedic teams or the intensive care unit teams who have interesting leadership models, and there is a stable, strict hierarchy in terms of who the responsibility lies, especially when things do go wrong. Do you think there's a need for a balance between, of course, the compassionate leadership, but also a stable, healthy hierarchy?
I don't think it's about balancing compassion and hierarchy, no. If I'm having open heart surgery and I start to hemorrhage, I don't want the surgeon to say, well, let's kick around some ideas here. I want somebody to take decisive action. And that's right and appropriate that we know what our roles are and who's responsible in what situation. However, what I really want to know as well is that at the end of the surgery, maybe at the end of the shift, that group of people sit down together and say, okay, in a very non-hierarchical way, what went well, what didn't go so well, what can we learn from this, where everybody's voice is valued equally. And so for me, it's not about balancing hierarchy and compassion. Compassion, I think, is fundamental. But it's about ensuring as well that we have clear roles and that we're constantly learning about how we can deliver care more effectively. Does that help?
It does make sense. Thank you.
Thank you. So let's move on a step. So it's about compassionate and collective leadership, but we also know quite a lot from studying organizations across the NHS in terms of what works and doesn't work about the key cultural elements which characterize high-performing NHS organizations. So in other words, you go to these organizations and what you learn is the organizations that perform best have these elements in place. What that means is that as leaders, we've got so much we can be doing in our days, but as leaders, it's saying we must focus first and foremost on these elements. to ensure the effectiveness of our organizations. So the first is the importance of having a clear vision and sense of direction. So what this is saying, look, people working in these complex organizations, it's really important that we know what our organization is seeking to achieve. And that's clear and simple and straightforward for everybody. Because what that does is helps us be clear about where we should be directing our efforts. It also gives us a feeling of pride in our organizations. And that matters to us. When somebody asks us, well, where do you work? Do you say, oh, I work in the King Fund? Or do you say, proudly, I work in Northamptonshire, NHS Foundation Trust? But it needs to be simple and understood, and I applaud the strategic narrative that you've got here to be a leading provider of outstanding and compassionate care, delivering in partnership, innovation, growing our staff capability, building sustainability, quality and safety, those 5 areas, and the key behaviors. And the more we can understand what those key directions and behaviors are, the clearer it is for us about what we need to do in our organizations. And we know that that kind of clarity is associated with lower levels of staff stress. But what we also know from our research is that, well, let me tell you a little bit about the background. In looking at cultures of high quality care across the NHS, one of the really riveting, exciting things we did was to analyze the board meeting minutes from 71 trusts over an 18-month period of their meetings to answer the question, what are they talking about? 80,000 pages of the most exhilarating material you can possibly imagine. And what we found was that, of course, every trust has a vision statement. What we found was that in many instances, these boards were talking about productivity, cost efficiency, the visits of the regulators, the financial performance. All important issues, of course, but often eclipsing discussions of quality of care. So although the vision statements were all about high quality care, very often what the boards were talking about excluded high quality care largely. But what we also found was that where that was the case in the National Staff Survey, though the staff in those trusts reported less commitment, less trust in their leaders, not feeling supported to deliver the quality of care they wanted to deliver, and had lower levels of engagement. What we pay attention to as leaders and what we monitor and what we talk about tells people in our organizations what it is we value. So it means that as a leadership community, we should be thinking every day in terms of our leadership, how can I support those I lead to ensure we're a leading provider of outstanding and compassionate care? That should be the focus of my leadership. What I'm talking about, modeling, thinking about, rewarding, encouraging, should be predominantly focused around that issue. That make sense? So Mersey Care, for example, another mental health and community trust, has as its vision striving, or mission, striving for perfect care. It's great. But what it means is that all of the leaders in the organization should be thinking all of the time about what can I do as a leader to support staff, to enable them to deliver perfect care for service users and patients in our community. Make sense? Yeah. So first of all is vision, and the second is it's great to have a vision, but then we need to translate that into action, into what we focus on. And what we've seen across the NHS is priorities. So the regulators are setting priorities, the Department of Health sets priorities, NHS England sets priorities, your board sets priorities, directorates, the 3 directorates set priorities. And we came to call them, in our research teams, the priority thickets, because there were so many priorities, no one could see what was important anymore. So many initiatives, so many priorities. Yet we also know that from 30 years of looking at healthcare teams across the NHS, that the most important determinant of the performance of healthcare teams is, rather parochially, prosaically, boringly, it's whether they have a limited number of agreed challenging objectives, 5 or 6, starting with the executive team. The executive team has 5 or 6 clear team objectives, then that team works much more effectively, and actually the whole organization works more effectively because there's less silo working. But very often what we see is executive teams that say, oh, well, our objectives are the corporate objectives. Well, actually, that's not the case. You're not delivering the care. Your role as a top team is to support the organization to achieve what it wants to achieve. So it begins with the executive team, specifying what the key directions of the organization are. And you've done that here in Northamptonshire, so there's a refreshing clarity of direction, but it must then apply to every team within the organization. So every team at every level having clear, agreed, 5 or 6 clear, agreed objectives. And they should be challenging. So we know that the more challenging objectives are, the better people perform and the more motivated they are. So what that also means is that, you know, if you impose ridiculous objectives on people, of course, they're demotivated. So they have to be agreed, negotiated, but they should be challenging. We should be aspiring to really make a big difference to the health and well-being of the people we serve in our communities. Make sense? How are you doing? Any questions so far? So those first 2 points about leaders embodying the vision in the way that they lead, and secondly, making sure that all our teams and ideally all individuals have 5 or 6 really clear objectives, and we're using most of the data that we collect in the organization. We should be using that data to feed back to people and teams about how well they're doing against their objectives. You know, what better use can we make of data in our organizations? So I'd like you to reflect on those first 2 points. Again, let's just take a quiet 20, 30 seconds for you to reflect on those first 2 points and what it means for your leadership. Is that clear? And then I'll ask you just to share your perceptions around your tables. So just 20 or 30 seconds to reflect on these 2. Okay, and if you please just share around your tables. Can I sit and listen? Thanks.
And they'll do a list.
One of the things we talked about was that the word performance was kind of an interesting one, and that often we feel maybe performance isn't always conducive with compassion, and that sometimes it's about meeting those targets, whether that's about, I don't know, mandatory trainings, contacts, waiting lists and whatever, and it becomes more performance focused, and you can kind of lose the compassion in that, and it's maybe difficult to measure compassion, but it's easier to measure quantity or numbers. And so that's where I think it's sometimes challenging to embed compassion when you've got these targets that you need to meet.
Did everybody hear? Yeah. So I think it is important to measure compassion. So what we're recommending, we're working with NHS Improvement, we're recommending that trusts use values-based appraisal and values-based recruitment. So to use that appraisal conversation and the PDR conversations to focus on those behaviours rather than just having a kind of focus on, as it were, hard performance metrics, because it's the compassion which delivers those outcomes. And if we don't change the culture, then it'll be much more difficult to respond to the challenges we face. Really helpful comment, thank you. Others? I was sat on this table here, which is no one's raising their hands. And while I was there, they made 53 separate points, I counted.
Not 53, I weren't counting.
Christine, you're volunteering. Okay. No, quick comment.
You heard what I had to say.
Somebody on the table?
As I said, I think
There you go.
compassion comes naturally to people.
Yeah,
You either have it or you don't, and you do need it in leadership.
yeah. Okay,
I
please.
think it echoed really what the other table was saying, that if we get the culture right, that will deliver those objectives, but that's the harder bit, but we have to keep our focus on that, and
So
the
if
end
you-
results will come.
If you get the culture right, Joe, it will deliver the performance. And that's exactly what we find in all of our research. If you get the culture right, it delivers the performance. If you focus just on the performance and neglect the culture, then you have problems. And we can train people to be much more compassionate. We can train people to be present. We can train people to listen. We can encourage people to use reflective listening techniques. We can use mindfulness training, emotional intelligence training, and helping people develop compassionate leadership. And I'll show you some resources at the end that are available to you where you can find out more about these issues. Someone over here?
Hello, I'm Amanda.
Hi, Amanda.
On our table, we were talking about competing priorities and the conflict that can cause for people. And we discussed how listening to what the issues are and the concerns, and perhaps adding in some extra support about how as a leader you can help the staff or those individuals to reprioritise what it is that they need to do, and to actually give them some extra support, and at the end of the day to acknowledge the value that they've added, and to make them feel valued, and that, you know, the extra work that they've put in. So that's what we talked about.
So I think those are really powerful points, is listening, the dialogue that's so important, that's missing in many NHS organisations, taking the time to listen, and then working with staff to find solutions to problems, not feeling that we as leaders have to come up with the solutions, but working with people to explore ways of responding to the challenges, but constantly appreciating and valuing the enormously compassionate work that staff do. Actually, whether it's people, not just people who have frontline or patient-facing responsibilities, but people in HR and finance and estates and other areas as well. Great, thank you. Any other compelling points you want to make? Okay, so we move on. The third point is, remember it's saying what our research has identified is the key cultural elements of high-performing organizations. That means this is what we as leaders should be focusing on. And the third is the importance of good people management. And I've talked already about authentic leadership and open leadership, supportive, positive, appreciative leadership. The National Staff Survey data, which we've collected for the last, what has it been now, 13 years of data. What's really valuable about the National Staff Survey data is that we're able to look at how changes are occurring over time in the NHS. So we know that from 2003 to now, in 2003, about 66% of people reported having an appraisal conversation. Now it's up to 86% nationally. We also know that the percentage of people reporting having had a helpful conversation has barely shifted from 38 to 39%. Yet we know that if you have a helpful conversation, your engagement subsequently goes up. If you don't have a helpful conversation, your engagement subsequently goes down. So it's really important that, you know, we're not just ticking boxes of targets around conversations, but making sure that they're really helpful, that they're focused on helping people be clear about what it is they're required to do, helping them to do their jobs better, and helping them, to take Amanda's point, helping them feel valued and respected and supported within their organisation by their leaders. And we're also able to see what trusts are doing these things well: stress, engagement, appraisal conversations. So we can go to them and say, wow, this is impressive. How do you do that? When you look at the staff survey data for this trust, on the whole, actually things are looking reasonably good in comparison with other trusts. But if you take in some areas the trusts that are doing better, then there's still a gap. That are doing best of all in particular areas, there's still a gap to close. I think we should be beating a path to the doors of places that have sky-high engagement scores and saying, well, how did you do this? Let's learn from you. And we're able to link the data from the staff survey to national outcome data: patient satisfaction, patient mortality, care quality, financial performance. And what that tells us is that there's a strong, really strong link between what staff experience from their leaders and what patients say about the quality of care they have. So the more positive staff are about their leadership, the more patients are likely to say that they're satisfied with the care they're receiving, that they're treated with respect and care and dignity. You know, when leaders are appreciative and respectful of those they lead, that behavior ripples out to the way we interact with staff and people in the community. When staff say they're under high work pressure, patients say in the acute sector there are too few nurses and they're not treated with respect and dignity. The more staff report high levels of stress, poor well-being, the worse the patients say is the quality of care they receive. Moreover, the more stress that staff are under, the poorer is care quality subsequently. So we look at CQC indicators, the worse is care quality, the worse is financial performance. And in the acute sector, the higher the levels of patient mortality. So there's a really clear relationship between what staff experience and the really important outcomes, the performance outcomes, you know, that we're concerned about. And it's just, we've got 13 years of data that it's so clear when we look at these relationships. And we know that engagement is the key predictor in the staff survey. Engagement, you all hear about staff engagement. It's another lovely word like compassion, but what does it mean? So the man who developed the concept, a man called Daniel Kahn in the 1990s, said, imagine an actor going to perform on the stage at the Royal Court Theatre on a Saturday night. Engagement is the extent to which she brings her life experience to the performance of the role, her compassion, her emotional intelligence, her courage, her energy to the performance of the role. So if you transpose that to when we talk about staff engagement in the NHS, we're saying staff engagement is the extent to which staff bring their life experience, their emotional intelligence, their compassion, their commitment, their energy, their courage to the performance of their roles. Why would they do that unless they really trusted their leaders and felt appreciated and supported and valued by those who lead them? And we know something about the key factors that are to do with feeling valued by colleagues, work pressure. So, you know, we were talking here about work pressure. We know that there's what's called an inverted U-shaped relationship between work pressure and engagement. So a little bit of, you know, quite high work pressure is associated with quite high engagement. Very low pressure, almost none, is associated with quite low levels of engagement. Very high levels of work pressure, sustained work pressure, are associated with lower levels of engagement because people are just so burned out by dealing with all of the work pressure that's on them. Make sense? So we can also know which trusts have been really successful in developing high levels of engagement. And then say, well, what is it about them what's characteristic of what they've done? And the first is, these are trusts like Northamptonshire which have a compelling strategic narrative. I've got an example up there of an organization that has had the same kind of vision or mission statement since it was created 150 years ago. The happiness of all of our staff through their worthwhile, satisfying employment in a successful business. Anyone know what organization that is? John Lewis Partnership, yeah. 150 years, the same statement, and they're always 1, 2, or 3 in levels of staff engagement, always 1, 2, or 3 in levels of customer satisfaction nationally. Second is, these are organizations that have retrained all of their leaders to adopt a much more positive, supportive, compassionate, inclusive leadership style. Not by sending people away on training courses, but by developing a climate, an ethos, a set of values within the organization, using coaching and mentoring, and having events like this. It's really courageous of you to have a week-long set of events to create a shared culture. Third is there are organizations that have delegated responsibility. You were talking, Joe, about delegating responsibility, weren't you? They've delegated, Sharon was, they've delegated responsibility to staff for service improvement. So they've given staff the skills to do quality improvement projects. They've given them the time and the resources to take over responsibility for quality improvement in the organization rather than top-down dictate. So Wrightington, Wigan and Lee there worked with Unipart, which is a car parts distributor, and adapted the lean quality improvement techniques they use to train their staff in quality improvement skills. So it's not just kind of saying, we want you to do this, it's giving people the skills and the time. They've trained 350 quality improvement champions, and you get gold and silver and bronze awards. You get a bronze if your quality improvement idea has been implemented in your area. You get a silver if it's been implemented in another part of the organization, and you get a gold if it's been implemented in another organization altogether. And at any one time, they've got like 150 improvement projects going on. So they've given the time and the resources and the training. I went up there about 18 months, 2 years ago, I think it is now, to attend their engagement committee meeting to see how they were achieving the very high levels of engagement that they had. And they kept talking about the horse. Some of you will be familiar with this story, but so I asked the question, and they told me the story of a patient who was dying sadly on the palliative care ward, Sheila Marsh, and one of the nursing staff said to her, you know, she had just a few hours really left to live, probably. Is there anything we can do for you? And she said, I would really, really like to see Bronwyn again. And it transpired that Bronwyn was the horse she'd raised over a 25-year period because she worked at Haydock Park Racecourse all her life. So the nursing staff got into a huddle, and they picked up the telephone and called the family and said, can you bring the horse into the hospital? So the family arranged for a horse box, and they brought the horse in, and Sheila Marsh was taken out onto her bed into the car park, and the horse clearly recognized her and nuzzled her and kissed her. And somebody had a camera phone and took a picture, and it's been seen by millions of people around the world. And it was really moving for Sheila Marsh, who sadly died just a few hours later, and very moving for her family, who were really appreciative of what had happened. And it was really affirming and moving for the staff as well. So nobody called health and safety. Because there was a culture of engagement and compassion, staff did the right thing and they were supported. The challenge for us is how we create those cultures. And the fourth element that emerges is the importance of trust. It is the most important factor in determining levels of staff engagement is the extent to which staff trust their leaders, that they feel they are treated fairly, that opportunities for career progression, for promotion, it's fair, it's open, that leaders don't have favorites who they spend more time with and give more interesting projects to. And all of us as leaders are guilty of creating in-groups and out-groups, the people we like a bit more, we feel more comfortable with, the people whose success we see as being due to their ability, and out-groups, the people we feel less comfortable with, who are not quite like us in some way, and whose success we see as being due to the particular projects they've been lucky enough to work on. And the more we create in-groups and out-groups, the less fair does the organization feel. And fairness and trust is fundamental to engagement. And what emerges from the data in the staff survey as well is the huge importance of discrimination as a barometer of trust in organizations in the NHS generally. And we have a major problem, and it has been a chronic problem. It's still the case that if you have skin this light color, you're 1.7 times more likely to be promoted to a leadership position in the NHS than if you have skin of a dark color. It's still the case that you're 7 or 8 times more likely if you have skin of a dark color to find yourself in disciplinary proceedings. The most discriminated against group in the NHS from the data that we have is people with disabilities, ironically enough. And then, of course, I've mentioned BME staff, people of Muslim religion. And it's absolutely essential that as a leadership community, we begin to address the widespread discrimination in the NHS in every team within the organization. So every team leader must take responsibility for an inclusive approach that values everybody and that values difference. Actually, all of the data we have is the more we have diversity of opinions, of professional backgrounds, of demographic backgrounds, the more creative and innovative our organizations are. And the last point is there. Angela, how long have you been here? Sorry, 64 years, did you say? You only look about 20.
4 years as chief executive, but I've been
around
for a lot longer.
So the longer your chief executive is in post, the more engaged staff tend to be, and the average length of time is 2 years. So 4 years, that's fantastic. I noticed the very stylish ball and chain on your ankle, that they're keeping you here. Anyway, so engagement. And the other important point I want to make is that to be effective leaders, we have to understand what it is to be human. And positive emotion is hugely important in human behavior. So the more positive emotion we experience in our lives, the longer we live. If you have positive leaders of teams, who was talking about positive leaders of teams over here? This is my home team here. The more positive the leaders of teams, the more cooperative and cohesive the teams, and the more compassionate care they provide. I can tell you're doctors, some of you. Which of you are doctors? Yes? It's a very reluctant nod. It's safe. What's your name, sorry? Sadish. If we induce positive emotion in Sadish, he will make better medical diagnoses. If we expose Becky to the common cold virus, but first we induce positive emotion, she's less likely to contract the virus. Chronic negative emotion is really damaging to human health. Positive emotion is really helpful. So there's enough negative emotion in the work that we do in health services without adding to it unnecessarily by the kind of top-down, punitive, command and control, angry leadership style we sometimes see in parts of the NHS that creates cultures of blame and fear. And we've talked already about negative emotion and how we deal with that. But it's also you know, I'm not suggesting, by the way, that what you have to do as a leader is come to work every morning with a kind of Ken Dodd personality. It's about being authentic and open and curious and appreciative and compassionate. But it's also about if we tolerate within our organizations aggressive, intimidating behaviors, really poor performance, then what we're saying as leaders is that's the way we do things around here. I certainly experience in many NHS organizations, particularly senior, often medical staff, who are intimidating or aggressive in the way they behave. That is as dangerous to patient care as medication errors or dirty wards, because it makes people afraid to challenge what they see as maybe unsafe behavior. It makes it that much more difficult to have a post-action conversation about what went well, what didn't go well. So as a leadership community, we have to deal with chronic, intimidating, difficult behaviors, as well as with poor performance. Make sense? How are you doing? You okay? So the fourth point is the huge importance of innovation, which we've kind of talked about already. By the way, we've just, in May, completed a review of the literature on innovation and quality improvement in organizations, and specifically in healthcare organizations as well. And we've been able to identify what the key factors are that need to be in place for innovation. And compassionate leadership proves to be really important. In the NHS, we tend to focus on, in terms of innovation, and it's one of your key values, it's one of the Digby Q points as well. We tend to focus on giving people the skills and capabilities and managerial encouragement of innovation, but these other factors are equally important. We have to have an inspiring vision and strategy. Well, we've talked about that. You have an emerging, really clear narrative. It's about living it as leaders. We also have to give people autonomy and support. So we began doing, I had the privilege of beginning to do work on innovation in the NHS in the 1980s, looking at innovation among student nurses, highly motivated young people, very intelligent young people, coming into nursing training, which was highly restricted, highly controlled, very hierarchical. So inhibiting their ability to express their creativity. And the turnover rate was something like 37 or 38%. People just quit. Then we changed to look at health visitors who had much more autonomy, much more freedom, and very high levels of innovation. It was a study of 98 health visitors in Sheffield. But everything that we've done since in looking at team working and innovation in the NHS has revealed that the more autonomy and freedom people have, in other words, the less hierarchy, the less bureaucracy, the less regulation, the more people are likely to innovate in their teams. And it's also about providing support. Again, the higher, if you look at the relationship between work pressure and innovation, we see that inverted U-shaped relationship. Very low pressure, low levels of innovation. Moderate pressure, high levels of innovation. Very high work pressure, low levels of innovation. People just don't have time to develop and implement new and improve ways of doing things. So it's not enough to say, we want you to improve quality, regardless of your workload. As leaders, we have to address the issue of unmanageable workloads amongst those we lead. We have to address that issue. So Birmingham Women and Children's Hospital, recently I had a conversation with them. They started a program of listening exercises to find out what their staff were experiencing. And what they learned was that junior doctors, like junior doctors across the country, were under intolerable pressure. Gaps in rotas meant they were working very often in really unsafe conditions that were putting huge pressure on them. So they convened regular Thursday morning meetings, initially composed of consultants, other clinicians, junior doctors, finance people, HR people, to address the issues. And together they began to come up with ways forward. They redesigned 34 rotas, which was a huge undertaking, created new roles of physician associate and clinical assistant to support the work. And the chief executive, Sarah Jane Marsh, meets with all of the junior doctors now on a regular basis to reinforce their importance to the organization and their sense of identity and belonging in the organization. And they went from having 40% of junior doctors recommending them as a place to do training to 100%. And they're now a GMC kind of excellent case study. Compassionate leadership, we found, is core to creating the conditions for innovation. So the more we have compassionate leadership, the more that the intrinsic motivation and the fundamental altruism of NHS staff is nurtured. The more that we have compassionate leadership, the more we're likely to have cultures of learning where staff will take risks within safe boundaries and recognize that not all innovations are going to be successful. Very different from the kind of cultures of blame and fear that we see in some parts of our NHS organizations. The more compassionate leadership, the more a sense of psychological safety is created within teams where staff speak up about errors or concerns or problems. And the more that staff will develop and implement new and improved ways of doing things. And the research shows that the more compassionate leadership, the more teams are likely to be cohesive and optimistic, and have a sense of real effectiveness. Make sense? And it's also about creating the conditions where there is positive inclusion and participation. I've talked about this a little bit already, of hearing all voices, valuing difference of opinion, valuing the views of different staff groups, valuing the differences in demographic background, and seeing that that's a source of innovation and creativity. And most important of all, valuing the voices of patients, service users, and the communities, not just in a kind of, we go through a consultation exercise, but actually ensuring that what communities and service users and patients are saying is really having an influence on the way we run our organizations. And if you look at all of the literature on innovation, whether it's in Silicon Valley or microelectronics or oil and gas industry or manufacturing or health, the more that service users, customers, patients' voices are influencing the way we provide services and develop products, the higher the levels of innovation. And the last is the importance of team working and cross-boundary working. So we have lots of data and evidence about the importance of team working for organizations to be effective. And it's about having a relatively small number of people in a team, 8 to 12, where everyone is clear about their roles, and where the teams meet regularly to review their performance. And what the research tells us is that that has a huge impact on patient outcomes. What we also know is that the development of team working in NHS organizations is rather poor. So 93% of people in the staff survey say that they work in a team. And then we ask a number of questions that we think are key to defining teamwork. Number one, does your team have clear shared objectives? Number two, do you have to work closely together to achieve your objectives? Number three, do you meet regularly to review your performance and how it can be improved? So those three make sense? The figure then drops to to 40%. So we think that around 60% of people, 55-60% of people in the NHS are working in pseudo or dysfunctional teams. The more people are working in pseudo or dysfunctional teams in the NHS, in other words, the 60%, the higher the levels of errors that could harm patients or staff, we find, the higher the levels of stress, the higher the levels of injury to staff. In the acute sector, the higher the levels of patient mortality. We estimate, using the most conservative way of estimating, that if we could increase that 40% of people working in real teams to 65% in the acute sector, at a minimum, that would be associated with the prevention of 5,000 avoidable deaths per year across England. Teamworking, quality of teamworking in healthcare is not just a nice to have. It's essential to ensuring that we're delivering high quality care. I'm going to flick through these two that show those data to talk about, in terms of our leadership of teams. I'm not going to go through all of these. You, I hope, will all be able to look at these the presentation and take from it key guidance for your team leadership. But I want to pick out 2 or 3. One is resolving and preventing intense conflicts. Interpersonal conflicts in teams are a disaster for team performance. I mean, we all fall out from time to time. It's the chronic conflicts where 2 people are at each other all of the time, and there's this constant tension. That is a disaster for team performance. It's therefore a disaster for patient care. And we must not tolerate it as leaders. Second is the importance, I've mentioned a number of times, of positive group attitudes towards difference, whether it's difference of opinion or difference of background, of actually valuing difference, listening to all voices. And third is the importance, okay, so here's a really important kind of prescription. Every team in this organization should have as one of its 5 or 6 objectives improving the effectiveness with which we work with other teams in the organization or outside the organization to deliver high quality care. Every team should have that as one of its 5 or 6 objectives. And team leaders must lead that inter-team cooperation, ensuring that it's effective. Make sense? And the last point about teams is one that's really going to cheer you up. So we began work in the 1990s. We saw that teams were so busy, that people in the NHS were so frenetic. There was always so much work going on. And when the work pressure increased, the hamster wheel just span faster and faster. What should they be doing, Phil? So I was saying that, you know, what you see in the NHS is teams work harder and harder, and the pressure increases, and they spin the wheel faster and faster.
Slow down the wheel.
Yes, slow down the wheel, stop. So we began a program of research, and what we found was that the more that teams took time out on a regular basis to stop and say, what are we trying to achieve? How are we going about it? What do we need to change? The more productive and innovative they were. So keeping spinning the wheel faster and faster is counterproductive. Literally, productivity will be lower rather than higher. And the more innovative teams are when they take time out. And that research that we've done over the years, it's been in executive teams, in community mental health teams, in breast cancer care teams, in primary health care teams. We've always found the same effect, and it's been replicated in at least a dozen countries around the world. And there was a recent, what's called a meta-analysis. Everyone know what a meta-analysis is? Shake your head if not. Meta-analysis? No. So a meta-analysis is where when there have been lots of research studies on a topic, you gather all of the data from every one of those research studies and analyze it as a whole to give you a much more robust picture of what's actually been found. So this recent meta-analysis of 49 separate studies showed that teams that undertook debriefs, remember our discussion, teams that undertook debriefs or took time out are on average 25% more effective than teams that don't. So our responsibility of leaders is not just to encourage reflection and learning, but to require it. Make sense? So those 5 areas that I've talked about are what we should be focusing on as leaders. Vision, clear objectives at every level, and using data to feed back on performance. Enlightened people management and leadership. Encouraging innovation, creating the conditions for innovation through our compassionate leadership, and building into team and team working and cross-boundary collaboration. So how do you do this? Well, I've got the privilege with colleagues in the King's Fund and in another organization called the Centre for Creative Leadership of working with NHS Improvement to support trusts to ensure that they get leadership strategies in place which will deliver these cultures. It's a 3-stage process. The first is examining our existing culture and leadership. The second is designing a leadership strategy which will deliver the leadership that we need now and in the future with the skills and the capabilities and the values to create the cultures that we want. And the third is implementing it. We, 3 weeks ago, released the Stage 2 tools. There are well over 50 of them that focus on things like values-based appraisal, values-based recruitment, developing compassionate leadership, encouraging team reflexivity, team-based working, leading for innovation. They're all free to download and you can use them. And we're working with many trusts to implement this work. And do you know what's really missing right from the middle of this slide? Is Northamptonshire NHS Foundation Trust, because we're working with Northamptonshire as one of the trusts on this work. And there's a community of practice that you can join, but you can download the tools to help you in your work as a leader within the organization. So I've used up my time, and I want to finish where I started by talking about the importance of compassionate leadership. If you take nothing away from what I've talked about this morning, it is those 4 behaviors. I keep thinking that if all of the 1.4 million people who work in the NHS encounter compassionate leadership when they come into work every day, they take that back out with them to their families and their communities. And the 1 million people who use NHS services every 36 hours, if what they experience is compassionate care, they also take that back out with them into their families and their communities. That we as leaders are potentially a huge force for increasing compassion in our communities and our societies. So we can really make a difference not just in our teams, but in society generally. And it's much needed. But as Phil said, it's really important to make sure that in order that we have the resilience and the capacity to be compassionate in our leadership, that we practice self-compassion, paying attention to ourselves, understanding the challenges we face, caring for ourselves, and taking intelligent action to help ourselves in our lives, in our work lives, in order that we can be who we can be and stay close to the core values that give our lives meaning, like compassion, and enable us to have deeper and more authentic connections with everyone we interact with in our work and in our lives generally. So, a huge thank you for the privilege of sharing some ideas with you this morning. It's been an enormous honour and privilege for me. Thank you.